Good afternoon, everyone. My name is Steve McPherson, as Dr. Sheehan mentioned. My role at Haemonetics is the clinical educator. I predominantly support the go-lives. I come in and work with every area, whether it's cardiovascular surgery, trauma, liver, ECMO, VADS, intensive care. I provide education specific to those areas relative to how TEG may be used to help guide blood management with your patients. What we want to accomplish today is just to give you an understanding of what TEG is, its application in specifically trauma is what we're going to talk about, as well as cardiovascular surgery. And if you elect to use it in those environments, how the values derived from the TEG assay will help you guide blood product administration for your patients. And I'm going to be talking about some values that are going to be fairly foreign to you. And listen, I get it. The first time I heard the TEG presentation 25 years ago, all I remember is blah, 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 TEG, blah, 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 TEG, RK, angle, MA. I will be here to help you understand what those values mean. I'm going to give you an introductory understanding of what those values and how they apply to the patient. And then when we're actually utilizing and launching TEG, I'll handhold you through that process and interpretation. It is fairly straightforward and it is pretty easy. It's just that they're different terms that you're not used to using, and as you get comfortable with them and as you actually interact with the tracings, it'll become much more easy for you to understand and interpret, okay? So what does the literature say about traditional coagulation? So we traditionally have utilized values like platelet count, fibrinogen count, PT-INR, PTT to understand what our patient's blood product use or need might be, and whether or not his or her blood is actually able to coagulate. And what we found over the years is that the traditional PT-INR and PTT, they're plasma-based. They don't necessarily incorporate platelets, and they don't necessarily incorporate fibrinogen into understanding exactly how well our patient's able to coagulate. In addition to that, when we look at platelet counts and fibrinogen counts, they're numeric values. They're quantitative. They aren't qualitative. So it's very likely, and I'm sure if I ask for a raise of hands, how many patients have we seen that have had normal PT-INRs, normal fibrinogen, and normal platelet counts, and they still bled, and we didn't quite understand why. It's because we're getting a number and we're not actually assessing the function. TEG gives you a functional analysis of how well all those coagulation processes are working in tandem. It's not a screenshot, it's not a specific shot in the process, it's the total coagulation process. And the values that demonstrate that to you, we'll be talking about. Traditional one's key points, no relation between PTT and anti-10A activity following cardiopulmonary bypass. For those of you who are involved in cardiac surgery, we found that these values do not guide you in understanding how well your patient is likely to need products during surgery or after surgery. Bruce Spiest, who's a cardiovascular anesthesiologist up in Toronto, did an extensive study looking at PTT and INR and fibrinogen concentrations, and he found that routine coagulation tests have no predictive value in showing regarding hemorrhage after cardiopulmonary bypass. TEG assays, if you're running them after surgery, we actually have a protocol, have identified significant amounts of bleeding that were relative to actually heparin rebound post-surgery. We'll talk about that as well. The unstimulated TEG test is one of the most sensitive tests for trace amounts of heparin. Again, and then this study here, thank you. We have shown that our TEG values return faster and cheaper results than traditional coagulation tests. This is a study done down in, can everybody hear me? Yeah. Okay. This is a study done down at Memorial Hermann. Brian Cotton, John Holcomb presented this study back in 2014 out of Memorial Hermann. We're going to be looking at two different processes when it comes to blood coagulation. There's the extrinsic pathway, which is involved in trauma and or what I refer to as controlled trauma surgery. So the extrinsic pathway, I'm not going to test you guys on this, but specifically is when we have trauma, tissue factor is released, tissue factor cleaves fibrinogen or actually activates the F factor 7, which actually ends up down in the common pathway for factor 7A. And then we also have the intrinsic pathway, and the values we're typically looking at here is PTT, and I'm going to back up, and this is PTINR. Go forward again. This is a longer pathway, and again, it concludes down in the common pathway where factor 10A is produced. And then after the common pathway, we go into prothrombin in the presence of factor 10A, and calcium thrombin or 2A is produced, which cleaves fibrinogen into fibrin monomers and fibrin polymers, but also activates the platelets. And that's very important. Activates the platelets on the PAR1 receptor, and the PAR1 receptor actually causes degranulation of a specific granule. It's called the alpha granule, and that alpha granule releases lots of what I call sticky stuff, more thrombin, fibrinogen, and it all accumulates around the platelet. And as it accumulates around the platelet, it actually causes platelet-to-platelet connection. And we're going to talk a little bit about that, but only on a high level. The reason I have this coagulation cascade up here is not for you guys to have to search back through your memory when you saw this in nursing school or med school or in anesthesia school, but to identify the positive feedbacks. So this is a very dynamic system, and it's important that we bring it all, and that's what TEG does, brings it all down to a dynamic process. And so we're not skipping any of these processes. The positive feedback that the platelets provide, the fibrinogen provides, and the actual damaged tissue provides in an ongoing process helps us better identify what the appropriate administration of blood products would be. So routine coagulation tests, the PT and PTT, are based on a cascade model of coagulation, which is still very important because we actually see that on the platelets as well. But it measures the protein interaction in plasma, so thromboplastin. It excludes the cellular components that I spoke of just a few moments ago, platelets, monocytes, and blood. And it determines adequacy of coagulation factor levels. So we're looking at the coagulation factor levels in circulation. It's a use a static endpoint. It ignores altered thrombin generation, which we'll talk about lightly, ignores cellular elements, and ignores overall clot structure. So the cell-based model is what TEG is based off in almost all of the whole blood assays. So light transmission aggregometry, platelet function assays, they're all based on whole blood. So they're not plasma, and those blood products are not spun out. Reflects more in vivo, it helps us see what's occurring on the cell surface, tissue factor bearing cells, platelets, overlapping phases, so the initiation or the tissue factor bearing cells, amplification of the platelets, and then the propagation. So when we're looking at platelet aggregation, it's a three-step process. There's the actual activation, amplification, and aggregation. We'll talk a little bit about that as well. The coagulation cascade is still important, but are cell-based versus plasma-based. And extrinsic, so we're looking at surface of the tissue, factor-bearing cells, and the intrinsic pathway, which is the surface of the platelets. So routine coagulation tests do not include these components. So real quickly, here's the initiation or activation. And what happens? Tissue factor is released from the damaged tissue, and oh by the way, other platelets that are aggregated along that damaged tissue. That's the initiation, and we have a small amount of thrombin that's produced during that initiation phase, and that activates the PAR1 receptor on the platelet, which causes the degranulation of that alpha granule, and that alpha granule releases, like I said earlier, all that sticky stuff. So more fibrinogen is released from the platelets, and then lots of thrombin. And that's where we get that large 2A. And that thrombin now activates another receptor called the PAR4 receptor, which really causes the amplification of the platelet aggregation. So now we have this small lining over the incision, and then we want to build a clot. That PAR4 builds that clot. So it connects, brings more platelets into the mix and creates that fibrinogen net over it. Does that make sense? Okay. Is this new stuff to you guys? Good to hear. Thank you. So the components of the cellular elements are the subendothelial cells and leukocytes. They express tissue factor. So when the damaged tissue, the blood comes in contact with the subendothelium, it releases tissue factor. Tissue factor activates the platelets, provides a reactive surface for coagulation and activation of the binding of tissue factor and factor 7A complex are formed, leads to a burst of thrombin generation through that PAR4 receptor that I was speaking of, which releases factors 10, 9, 8, 5, and 11, and which is fibrinogen, and expresses phospholipid surface membranes. So the platelet goes from that discoid shape to that morphological shape where it looks more like an amoeba, which increases the surface area for activation of what's referred to as the glycoprotein 2B3As, 1B, 1X, those receptors which connect platelets to platelets through fibrinogen. What is the TEG analyzer? It's a real-time analyzer for whole blood for coagulation. It measures the viscoelastic properties of the clot. The clot has 3 main systems and 5 affecting processes. So we're going to really quickly go over that. So here's the clot, or plug, if you will. The system is first the enzymatic system. So we're looking at thrombin production and or lack of production. Thrombin is the most potent activator of platelets. It cleaves fibrinogen into fibrins so that we can create that mesh over the platelets and hold them in place. It also creates the connection from platelet to platelet. Oops. Then there's the platelet system. I talked about the PAR1 and PAR4 receptors, activation, aggregation, and then in the presence of fibrinogen, adhesion to one another. And then the clot goes through normal breakdown or lysis. There's both a physiologic and pathologic, and the primary ones we are familiar with is primary fibrinolysis and secondary fibrinolysis. Secondary fibrinolysis would be like DIC that you would see up in the ICU, and or a patient that comes in that's had an infection process for a period of time. So that's the actual total fibrinolytic system. Objectives of TEG-guided therapy: to express function and pinpoint dysfunction in the hemostasis system, and acts as a reference for the types and amounts of blood products needed to correct the bleeding from dysfunction. It allows accurate anticoagulation or antiplatelet interventions to reduce thrombotic complications without inappropriate bleeding. So we can actually identify on a TEG tracing how a patient may or may not need antiplatelet therapy. All right, so objectives again, guided therapy to distinguish between anatomical and coagulopathic bleeding, to distinguish between primary from secondary fibrinolysis, including the consumptive phase, and to reduce the use of unnecessary blood products and reduce thrombotic complications. So limitations of TEG testing: von Willebrand's disease. So if you have a normal TEG tracing and your patient's still bleeding, you might want to suspect that he has von Willebrand's deficiency. Because what's happening is that even though the patient's building a nice clot or is capable of building a nice clot, there's not enough von Willebrand to actually connect that clot to the damaged tissue, right? Lupus anticoagulants, protein CNS deficiency, factor V Leiden or HIT. So in these two right here, you might have a hypercoagulable patient, and it's going to be enzymatic, and I'll show you what value indicates that. It's going to be enzymatic, because they're actually making enough thrombin rapidly that you're going to have an enzymatic hypercoagulation state. Again, we'll tell you they're hypercoagulable with a tag tracing, but we're not going to be able to actually help you identify or differentiate what that is. Cardiac surgery, there's actually a TEG protocol developed by 2 interventional cardiologists and cardiac surgeons. I think there's over 1,200 patients in these studies. What they did is for those of you who are in cardiac surgery, Society of Thoracic Surgery has determined if there's any patient on antiplatelet drugs, you need to wait 5 to 7 days before they can go to surgery. The question is, how many of these patients are actually therapeutic and how many of them are even responding? And I've seen studies as of late that have demonstrated up to 64% of these patients that are on these antiplatelet medications are non-responders. And so you wait 5 or 6 or 7 days, well, then you're putting that patient at risk. Plus, if it's if he or she's in a hospital, they're waiting a lot longer than necessary. TEG platelet mapping can help you identify those patients, whether they're therapeutic, or whether they're safe to go to surgery, and we'll talk a little bit about that. This just happens to be a standard TEG protocol as to when you would actually run TEGs in cardiac surgery. The baseline would be the platelet mapping to identify the patients at risk for bleeding and/or what blood products you may need. The rewarming phase is just to identify how well the platelets are functioning as that patient is coming off bypass. They're getting bumped around a little bit. They're going to be a little agitated. Perhaps they'll be hypercoagulable, and/or maybe there's not enough fibrinogen because it seems that pump seems to not consume fibrinogen but oxidizes it a little bit, so the fibrinogen may not be functioning as well as what it should be. So TEG can help you identify that. And then what we do is post-protamine, we'll see how well the heparin's been reversed. We can run a TEG and see how well that patient's able to build a clot. And then post-op 2 hours. And again, that's to look for any heparin rebound. I have hospitals that have incorporated this protocol and reduced their product utilization by 80%. So here's what a TEG tracing might look like. This is a cartoon representation, if you will, and I'm going to go through this real quickly. So the blood is introduced into the cup that your lab people will be running right here. And this time from here to here is the reaction time. In your mind's eye, the blood is actually in this cup, and there's a little pin that's sitting there, and the cup rotates, and it rotates at a 45 and 5 degree angle. We're attempting to mimic what's going on in the vasculature, so it's going 5, 45, 5, 45, and kind of like how the heart pumps. Boom. There's a little bit of backflow when the ventricle dilates. We use 5 degrees as that. So we're trying to mimic the in vivo process. And as that blood begins to coagulate on that pin, the pin begins to move upward. So the reaction time from here to here tells us the enzymatic process, how long it's taking for thrombin to be produced, enough so that it's activating lots of more platelets. So in your mind, again, think of this as this first incline here to be that initial burst of thrombin, that large amounts of thrombin from that platelet, which I've talked to you about the PAR 4 process. This initial would be how long it takes for that PAR 1 to actually get going, okay? So as the fibrinogen begins to accumulate and platelets are actually brought into the process, we start to see this incline. We use K here, that's clot kinetics. We use a 20 millimeter amplitude because it's felt in the literature, although I think more research is demonstrating that it's not necessarily true about everybody across every patient. Rather, that 20 millimeters or 20% of the clot strength is fibrinogen related. You're going to find that that's not true as you start using some of the assays. There are going to be patients that their fibrinogen contribution is 50 and 60% of their clot strength. So in those types of patients, if you're giving them platelet therapy and 60% of their clot is fibrinogen, the platelet therapy isn't going to work very well. So this tells us how quickly that clot is growing. The angle tells us how much fibrinogen is contributing to that clot. The width, or the distance, known as the MA, tells us how strong the clot is, and it's a reflection of platelet function. In the trauma patients and in some patients who have been on bypass for a long period of time, if it's a long case, we start to see TPA release, and plasminogen actually starts breaking the clot down too rapidly. And if you see LY30, lysis 30 over 30 minutes, if we see that greater than 3% in the trauma patient population, that's an indication that we might want to use TXA tranexamic acid to reverse that plasminogen activation. In the open heart patient population, I think you may use Amicar, I don't know. Are there any cardiology anesthesia guys or any cardiac surgeons in the room? Nurses? Do you guys use Amicar? Yeah. Okay. Use it routinely or, okay, prophylactically? Yeah, okay. So that's what the Amicar would do, is would reverse that from occurring. And in the trauma patient population, if it's greater than 3%, that's an indication that you need to give tranexamic acid if that's what you're going to be using. Do you guys use TXA at all in your trauma patient population, Dr. Sheehan?
We have it.
You have?
We don't have a way to really decide. We basically use the CRASH-2 data.
Okay. Yeah, you will be able to identify that, and probably in a trauma patient population, I see it maybe 1 in 8 patients, depending on the degree of the trauma. So that makes sense, folks? Now I'm going to show you some tracings here. We're going to talk about rapid TEG first. Okay, rapid TEG is what you're going to be using in your trauma patient population. And instead of an R value here, you're going to have a value called ACT in that place. And what that is, activated coagulation. And what we've done is we've added tissue factor to the reagent so that we're looking at both the intrinsic and extrinsic pathway. When we do just a standard TEG, we're just looking at the intrinsic pathway. We add tissue factor to this, and it expedites that thrombin production. So we get a quicker creation of that angle and tracing. So here's what a standard tracing is going to look like, folks. And you can run an overlap. See this dotted line? It's a normal. You can actually visualize these tracings at the bedside if you want. So as the lab begins, as Tom's team begins to run the assay, you send the blood sample down there. Within about 5 to 10 minutes, you should be able to actually it hitting the lab. You should be able to actually start seeing this tracing get generated at the bedside. And there's a software that's available to certain people that they can call this up and see this in real time. So here's the R time. And oh, by the way, these normal ranges may not represent your patient's normal ranges. We have to figure, Tom's team has already identified what those are. And so I'll speak to these generally, but don't hold me to these normal ranges relative to your patient population. So here's the R time, or ACT on your patient. And down here in the bottom of each screen, you have R here and the actual value and the range. And this is in minutes. The K, the actual value and the range. The angle, the actual value and range. The MA, actual value and range. And then G is just a reflection of clot strength in a dynamic environment. So we're taking into consideration shear force, so the flow of the blood, so the clot strength of 6.7, the range of 4.5 to 11. Patients that are in the 20 range on a G are very high platelet hypercoagulable. Those are patients that will either develop a DVT, a pulmonary emboli, and there's plenty of studies to help you understand that. And they should be either on a platelet drug, antiplatelet drug, or something to calm down the R or the enzymatic process. So maybe some of the anti-10As, Coumadin or something like that. And then LY30. So here's on this specific patient, it's normal. His R time is 6.8. You can see the range down here. His K, which is the clot kinetics, is here, 2.1. His angle is 63, which is a reflection of the fibrinogen contribution. And then his MA is 57, which is platelet. G is 6.7, and his LY30 is essentially 0. Here we have a patient that is hemodiluted or on anticoagulants. His R time is 10.5. Otherwise, everything else is normal. So if this patient were bleeding, and I need to emphasize that, if this patient were bleeding, the appropriate therapy would be to address his thrombin production. So if he's on an anticoagulant, reverse it. Or if it's a trauma patient, you may want to give him some FFP. Any questions? Okay. Here we have a patient that has a long R time again. Everything else is normal. Same thing. We have a factor deficiency, so you'd want to address that factor deficiency. So he's not creating enough thrombin, or the process for creating thrombin is slow, and if he's bleeding, then the appropriate intervention would be to give him FFP. His ability to create a clot is very good. So it's not a platelet issue, and it wouldn't be a fibrinogen issue. Here we have a patient that has a normal R time. His K is longer than normal, and his angle is less than normal. His MA is normal, G, etc. So if this patient were bleeding, the appropriate intervention would be cryoprecipitate, something with a greater amount of fibrinogen in it.
Is the dotted line the normal?
Yeah.
Okay.
Yep.
And the solid line is the patient's result?
Yes, thank you. And you can overlay that by just pushing a button, then you can see what it should be. And as you get used to looking at TEG tracings, you can look at the tracings themselves and you can get a real good indication without even looking at the ranges down here and identifying what the intervention may need to be.
I have a
Yes.
question about that. Where will the TEG tracings take place? So we draw blood in the ICU, either for cardiac surgery or for a trauma patient. First of all, how long do we need to get it down the lab? Is there a time frame before it needs to start processing? And number two, once it starts processing, is this a monitor, or where is this that we can actually see it?
View it. So the question was, and help me if I don't restate you exactly, is how long does it take to get the TEG tracing going, and how long does it take to get it down to the lab? How quickly should we get it down to the lab? Is that correct? And then, is there a monitor that we can actually visualize this tracing, and how long before we can actually begin to see it, correct?
Will this information just be available to the physician?
Or will this information be just available to the physicians, is the other component of the question. So the first part of your question is, once you draw the TEG sample, and I believe that it's tube system, Tom, is that correct? You're going to tube it down to the lab. So from the time you actually put it in the tube system, it may only take a minute for it to get to the lab. I'm not sure, but it's going to take the technician, if he's notified ahead of time, but if he's not notified, it's going to take him 5 to 10 minutes just to get the assays up ready to roll, okay? So think of it from a 10-minute period of time. If this is a trauma patient, and they are notified that the MTP is going to be enacted, they could actually begin to set up the assays immediately when they're notified before the blood gets there. So it's really a communication issue relative to that. And once you get those communications worked out as you move through your understanding and your journey with TEG, you'll be able to shorten that time frame down. The other part of the question is, the second part of the question is, there is a software, and it's called the TEG software, that's available to specific people in the hospital to view it. And Tom's team and Dr. Sheehan have worked that out. So I'm not sure if nursing is on that, Tom, But there's, so at this juncture, there are specific people that will actually pull that up.
I can just clarify that there is remote printing, it's just a matter of identifying what
Who?
rooms we want to put that in. So ED traumas, OR suites, ICU beds, and then just go on and on.
Okay, so Tom's clarified that further in that we're still working on identifying exactly where we're going to actually launch that and who's going to have access, and that'll be worked out through the process. And the third part of your question is it real time, and how quickly can you view this? As soon as the lab technicians enter the TEG sample into the machine, it starts analyzing, and you will, if you call this up 5 minutes, let's say it's 10 minutes later, if you call this up and the TEG tracing is beginning, you're just going to see this part right here, then you can actually start viewing it as soon as they actually start running the assay. Did they answer your questions thoroughly? Okay, great.
Just to clarify a little bit, the software is going to be placed on all the computers in the OR, all the trauma rooms in the ER, and the computer stations at the physician work area, and all the ICU computers, because we can't really pick who's going to be. So it's going to be a matter, it's going to be a separate sign-in, like sign in for Epic. It's an icon-based program, so you click on the icon, there'll be a sign-in. You get to it, you have to pick the patient from the list, and then as soon as you do, as soon as the graph starts drawing in the lab, the graph starts showing up on the computer.
And if time allows, I will actually show you how that process works. I've got the software on my computer, and I can show you quickly how that works. Yes, another question.
Is this a really expensive test?
I don't think it is, but it's all relative. Okay, so.
No, it's not expensive at all.
Yeah, we give it away. I don't think it's expensive. The assays cost are variable depending on which one you're running. So Tom's team has to build in lab technician, et cetera, but the cost of the assay, an acquisition cost, is anywhere from $10 to $13 for a standard tag. Rapid tag is, I think, $32. I don't know. And then the platelet mapping, which is the most expensive one, is about $115. So, and there's several different assays in between.
So this is predominantly just used with OR as well as traumas, correct?
That's
So what about hypercoagulable states?
a great.
Do you see these be utilized for those kind of people? Because I take care of the oncology population who
Are
at
hypercoagulable,
risk. Right.
yes.
So I was just wondering if this is something that,
So the question is, are there other areas of utilization of TEG outside of the OR and trauma? And absolutely, absolutely. So oncology patients, and I'm going to be talking to that a little bit here, a little bit earlier. Any patient that has an inflammatory process and or is getting an inflammatory process induced into their body, like with chemo, they are hypercoagulable and they are at risk for pulmonary emboli. They are at risk for deep vein thrombosis. So yes, there are folks using it for hypercoagulable states. So it's not just an OR and a trauma area product. It also is one for identifying how well your patients are anticoagulated or antiplatelet therapy. It's also utilized for patients who are in the ICU who may be at risk for other hypercoagulable processes like DIC, et cetera. So yeah, its utilization is outside of those areas, but initial introduction into a hospital is typically through trauma and cardiovascular surgery. That answer your question? Okay, great. Okay, so here we have a normal R time, normal K, normal angle, but the MA and the G are low. So what would be the appropriate intervention if this patient's bleeding? It's not FFP, it's not cryoprecipitate. It would be platelets. Did I hear somebody say? Yes, thank you. So you can see this is not too difficult to grasp when you first see it. Start using it. This patient has a shorter R time. Now, I'll tell you what, I kind of toss up on this value because, I mean, the standard deviation is plus or minus 1 on this. So I not necessarily would agree with this. This patient is enzymatically hypercoagulable, but the R tells us it is. So all the other values are within a normal range. I wouldn't treat this this was a patient that was a chemo patient. I wouldn't treat that R. Okay. Now this patient is a scary one. He has a normal R, normal K, angle's high, MA's high, and his G's high. This is a patient that will occlude. Okay? And the process, and his challenge is not enzymatic, it's platelet driven, very hypercoagulable. I had a patient about 6 months ago. We started, he had, he was pre-op for cabbage, 4-vessel off pump. And this is before I came in and trained them. They had some tags and they wanted to see what this patient looked like. And it looked just like this. It's the exact, almost the exact identical tracing. He had a G that was 23.5. Nobody knew that this patient could not interpret it. He had a normal platelet count, normal fibrinogen count, but he was horribly hypercoagulable. He occluded all 4 of those vessels within 24 hours of the surgery. His ejection fraction went from 50% down to 20. He ended up on a VAD, et cetera. This is real. If you see something like this, you got a patient that is going to, if it's surgical, he is going to occlude. He's at high risk for DVT or pulmonary emboli. He or she is, rather. Combination hypercoagulable, R's short, K's short, angles high, MA's high, G is high. This is the type of patient that you would probably want to consider some sort of antiplatelet therapy on. Aspirin at a minimum. Here's secondary fibrinolysis, or DIC. Patient has a very short R time, which is causing a lot of thrombin production and a lot of platelet activation, aggregation, and amplification. High MA right up here, 82. And what's happening is this, because of this hypercoagulable state, this patient is beginning to lyse that clot down, so he or she is going to begin to bleed. And what you'd want to do is calm this process down, put him on an anticoagulant, extend that R down, and reduce the amount of thrombin production, and we'd see these values come down. This is what he's going to look like if you don't do that. Okay? Now he's bleeding everywhere, and there's nothing you can do about that. Here's your primary fibrinolysis, those patients that have been on pump for a long time. You guys are using Amicar, so you're not going to see this. But your trauma patients that come in, this is a classic. I call it a Hershey kiss on its side, and it's the kiss of death. If you don't treat that plasminogen activation with tranexamic acid, look at the LY30, there's nothing you can do to correct. You can throw all the factors at him, all the platelets at him, all the cryo at him, all the blood at him. If you don't correct this, it's not going to reverse. You're going to see these in your blunt traumas as well. Dr. Sheehan, I'm often very surprised to see this in blunt traumas as well. When I think of this, I think of massive blood loss, but heads seem to head traumas, as well as any other blunt traumas, seem to have a high amount of fibrinolysis. Heparin effect. This is predominantly for those that would use this in open heart surgery and post-op. We have what's referred to as a blue cup, which is heparinase, and a clear cup, non-heparinase. So you put a blood sample in here, and you run these simultaneously. This is called the plain cup. This is called a blue cup or heparinase cup. And we can see what the patient's tag is on the white or clear cup, and then what it would be if there's no heparin in the blood. And so we look at this to identify, number one, is there heparin on board? And what is the patient's coagulation process without heparin? So here's where he or she would live, and here's where he or she is relative to the platelet or the heparin therapy. So we look at this to see how well they're reversed. There's often you can see postoperative bleeding on heart patients it's because there's heparin on board. It's getting recirculated a couple hours later. And if you run one of these tests, you can identify it and give more protamine. So it can differentiate whether or not this is a mechanical bleed or a physiologic bleed. Basically, and if the and then if with a patient like this, you give them protamine, this is what if you repeat that tag, this is basically what it would look like. Both of them would be identical. Any questions? Great. So what does a normal tag tell us? It measures factor deficiency, fibrinogen deficiency, platelet function, clot strength, lysis, can help you identify surgical bleeding from mechanical bleeding. So that those post-op patients that are bleeding a little bit, run a tag. If the tag's normal, then maybe he's either got a von Willebrand deficiency or you got a surgical bleed. I call it proline deficiency. Needs a little bit tighter stitching. One of the things I find a lot of folks doing in post-cardiac patients is to test if they suspect a von Willebrand. They give a little desmopressin. Do you guys ever use DDAVP? A little desmopressin will squeeze out some von Willebrands from your platelets and also introduce circulatory von Willebrands from the actual tissue cells of your arteries and veins. So that's a good way to test whether or not you need to take that patient back to surgery. Because if you get a normal tag tracing, if you give a little desmopressin, and it reverses, then you don't need to take the patient to surgery. Drug monitoring monitors heparin, low molecular weight heparin, Coumadin, Arixtra, these anti-10As, and the newer ones that are out there, Xarelto, et cetera. It excludes these drugs, the actual platelet drugs. And the reason it excludes is because we want to do what we call platelet mapping to actually identify what effect these drugs are having on the ADP process and what these drugs are having on, specifically here, are having on the COX-1 process, and then what these are having on the GP2B3A process. So the ADP process is Plavix, Effient, Brilinta, Integralin, Riopro, Aggrastat, and Pletol and Persantine are the GP2B3A receptors, which are the ones that get activated, or in this case inhibited, from being activated to connect fibrinogen to platelet. So we're going to talk, I'm going to stop here. Any questions at this point relative to regular tag? Yes, back there. So the question was, if you're giving Amicar or DDAVP, how long do you need to wait after you've given that to do a sample? 30 minutes is traditional, okay? The American College of Surgeon recommendations, or the TQIP, Total Quality Initiative Program, recommends these as your triggers for TEG and what products to use. So a TEG ACT greater than 128 seconds, they're telling you need to give plasma and RBCs. Oh, by the way, this is taken out of Ernie Moore's and Brian Cotton. Brian Cotton down in Memorial Hermann. They've done literally thousands of TEGs and ACTs. And the guys up in Denver Health, Moore, they've done an equal number of them as well. And they came up with these values that the ACS is using. So ACT greater than 128, K greater than 2.5, Ango less than 56, MA less than 55, and LY 30 greater than 3%. These would be the appropriate intervention. I was talking to Brian Cotton about a month ago. He not only uses plasma and RBCs when he's got that. He's also using cryo and or plasma and RBCs, cryo and RBCs, platelets and RBCs. Okay. Here's a TEG treatment protocol, and some of you have that, I believe, on the upper on this sheet back here. It gives you an understanding or appreciation of what the actual treatments may need to be, and it gives you a definition of how what those values mean. Also, when we go live, I'm going to have these little clinical guides in different areas of the hospital. I'll probably have some in ICU. I'll have them down in your trauma room, down in ED, and if anesthesia lets me, there will be one in every one of their carts. But it's basically a guide, and we have the treatment protocols in here on interpretation, what the values mean, and how you may want to interact with the patient relative to the values. Risk stratification with the tag analyzer, we're going to touch upon this. Assessing risk for thrombosis, and this will help address your chemotherapy patients a little bit. Goebel, who is an interventional cardiologist out in New York, and McGrath, also an interventional cardiologist. They're looking at ischemic events and how well TEG is able to help identify patients at risk for ischemic events. And in the Goebel study, he found that an MA, pre and post MA of greater than 65, elderly patients were at risk for a DVT. McGrath found a value of 68, so plus or minus 2. So those patients were at higher risk for developing a DVT. And here's it in a table format. Here's McGrath's work. So number of patients here and age, so 72 to 95. Number 56, if they had MAs that were greater than 65, they were at risk, 32% higher risk for a DVT or an MA. Goebel's study, pretty much, anything greater than 72, 60% event. Any questions? This is Brian Cotton's comment. When controlling for gender, race, age, and ISS, elevated MA at admission was an independent predictor of pulmonary emboli with odds ratio of 3.5 for an MA greater than 65. Now we're going to move on to platelet mapping real quickly. Platelet mapping measures the effect of antiplatelet agents on platelet function. It measures the patient's maximum platelet function as a reference point, so we know exactly what that patient's coagulation process is. So that's one of the key things about platelet mapping, is we actually identify what the patient's normal platelet or ability to develop a clot is, and then from there we can measure and test the different platelet drugs to see how well they're functioning relative to that patient's normal coagulation process. Measures the percentage of inhibition relative to the patient's own reference point, measures the percentage of inhibition related to other causes like herbal supplements. There are plenty of things that we take or we consume that affect platelets and your platelet function. So it won't be unusual for you guys to have patients who are inhibited on their ADP pathway, which is the pathway that the Plavix type drugs work on. It's not unusual to see them inhibited on that pathway and not be on any antiplatelet drugs. And they will bleed. So it could be dietary, it could be some of the standard medications. Almost all the statins reduce platelet function on the ADP pathway. Viagra's a big one now, unfortunately. That was a bad term. Anyway, Viagra inhibits the ADP pathway. Lots of nutritional supplements. Fish oil inhibits the COX-1 pathway, which is the aspirin pathway. So a lot of these patients will bleed that you may not know why, and it's because they're inhibited just because of something they're taking that you and I may not necessarily think about. So platelet mapping, pre-op. Does the patient have the potential to bleed during or after the cardiac procedure due to platelet inhibition? Platelet mapping will help you answer that. Should we wait 5 to 7 days or less to take the patient if he's on an inhibitor? Platelet mapping will answer that for you. Should the patient potentially put on a higher dose of the inhibitor and or changed completely? Because I've seen studies anywhere from 30 to 60% of these patients don't respond to Plavix. Maybe they should be on Brilinta, maybe they should be on Effient. Try it. And platelet mapping will help you identify whether they're therapeutic. Post-op, when there is a normal TEG reading and the patient is bleeding, Well, we should be suspecting von Willebrand's. We can rule it out with Desmo. Surgical bleed, rule out proline deficiency. Platelet inhibition as determined by the platelet mapping assay. So if the patient is platelet inhibited, we'll be able to identify that through platelet mapping. You'll be able to actually identify that before surgery. If the patient is inhibited and you have to give him some platelets during surgery, you're going to have to keep an eye on him or her post-op, because those platelets, when we're measuring platelet function, we're measuring the amount of platelets that are actually left over that aren't working very well, okay? Because those that are actually involved in the coagulation process are getting consumed. So here's how it works. You have a standard tag tracing generated from thrombin. So here's the baseline right here. And then we create an activator, and we isolate out fibrinogen. So this is telling us how much the fibrinogen is contributing to the clot, MA fibrin. So we're measuring here to here, and then for the MA thrombin, we're measuring here to here. And then we go ahead and isolate the ADP receptor, which is the Plavix, the Brilintas, the Effients, right? And we see how well the patient builds a clot when thrombin is inhibited. And what we know is if this MA ADP is greater than 50 millimeters, and this is from the Goebel, McGrath, and Shore-Lesserson studies, if the MA ADP, not the percent inhibition, but the MA ADP is greater than 50 millimeters, that patient is not at risk for bleeding and surgery. And he is not therapeutic on that drug. So we isolate out right here between these two right here, because we've isolated the fibrinogen contribution. So we're looking at the difference between these two right here. And here's a patient representation. Is ours normal? So he's got a normal functioning, tracing, excuse me. And his MA-ADP, which this will be expressed on the monitor, you'll see this value right here, is 36. This is the type of patient that would be at risk for bleeding. And you would want to wait, if it's between 30 and 40 millimeters, you would want to wait probably full 5 days before you took him to surgery. However, if this value is greater than 50, you could take him to surgery right now. Any questions at this point? So why platelet mapping? Well, you're going to have patients who are hypercoagulable, like we see over here in patient A, and he's on a platelet drug, and it's working, but it's not therapeutic. And so here's what his MA-ADP is. He's still hypercoagulable. Patient B, here we have the patient's hypercoagulable. And oh, by the way, the reason these patients are on platelet drugs is they're hypercoagulable. And the question is, are they therapeutic? And this specific patient, he's in a normal range, so he could go to surgery. This patient could go to surgery, but he's not therapeutic. Patient C has a normal tag tracing, but his MA-ADP is hypocoagulable. He would be at risk for bleeding. You'd want to wait 3 or 4 days, depending on the degree. If it's 40 to 50, probably 1 to 2 days. As we all know, platelets replenish themselves from the spleen about 10% every day, right? So the meds affected platelet mapping, the GB2B3As are Riopril, Integulan, and Aggrastat. The ADP process is Plavix, Prasantin, Effiant, Ticlid, Brilinta. TXA is aspirin and NSAID. NSAID products like Motrin really they're short-lived. Aspirin is for the life of the platelet once it's activated, or actually affecting the platelets for the life of the platelet. Same with these other drugs. The GP2B3As are shorter lasting, and they're actually becoming, you folks may be seeing these coming out, being used in your cath labs. Shorter life span, so they don't affect the platelet for the life of the platelet. Here's a patient before platelet mapping. Here's his or before inhibitor. Here's his tag. Here's his ADP, which is just slightly below what his normal tag is. And here's his fibrinogen contribution. Here's after they gave him his, a couple doses of Plavix. So he's now inhibited and actually protected. I think I've already talked about this, and I believe we're just about done. Timing of surgery. Here's the study that Mela and Shore-Lessenson and Goebel did. MA-ADP greater than 50, OR within 1 day. MA-ADP 35 to 50, 3 to 5 days. MA-ADP less than 35, 5 days. And it's just in a graphic form. Pathologic platelet inhibition, not platelet direct drug induced, may be due to foods, nutraceutical, or other medications. I've got a listing. There was a study done by a guy named Scharf in Germany and published about 2 years ago. And he actually has all the different drugs that we have patients on. We're a heavily medicated population. All the different drugs and how they affect platelets. And what you want to pay attention to on that table is, does it cause clinical bleeding? Because some of these will inhibit those pathways, but not cause clinical bleeding. But there are several of them, some penicillins that we take will cause clinical bleeding, and some of the other ones that I mentioned earlier. So platelet mapping is now, it will cover all of these medications that we would typically see. And that's the end of my presentation, and I went a little bit order. Question?
When you order a platelet mapping, you also get a tag.
Yeah.
So you'll get the tag tracing and the platelet mapping value as well, not just the platelet mapping.
That's correct.
Order a tag and a platelet mapping.
Yep. So when you do, if you order a platelet mapping on your patient, know that you're going to get a standard tag with that as well. So you don't have to order that additional assay. Any other questions? Yes.
Other studies that show, like you said, that some of them, the patients aren't therapeutic on their meds.
Mm-hmm.
Is there a routine study that shows that they would order that to see if they need their meds changed?
There are hospitals that do, yes. Goebel, McGrath, those guys who have done a lot of those studies are using platelet mapping to adjust the medications that patients are on. And you know, I see it happen slowly as physicians get comfortable with the technology. Then one begins to see them start to embrace it more in different areas. I have a hospital that started a year and a half ago up in mid-Michigan, not the hospital, but in the middle part of Michigan, where they started out slowly using it in open heart surgery, and then the cardiologist started following the patients post-op, and they began to appreciate the value of the information and started using it to adjust the drugs and or change the drugs. Yep. Yes.
Is the tag information sensitive to hypothermia versus a normal thermic patient?
That's a great question. So the question was, is the tag tracing sensitive to hypothermia? And yes, it is. So we want to know, if you got a patient that's hypothermic, we want to know that they're hypothermic because we can adjust the analyzer down to that patient's temperature.
So that information needs to be given to the lab?
Correct. Yep. Yep.
So it is a big communication issue.
Yeah. Yeah. In fact, it might be something we would want to include on the orders.
Yes.
You know, is
You
this
have to have a
patient?
current temperature.
Yep. What's the patient's temperature?
It has to be
You have a
temperature.
question? Hi, Jeannie.
I can review for all blood utilization, for appropriate use. Will the various values that end up populating along the way, will those show up in the chart at any point?
Yes, the question is,
We have to figure out what to do with the graph.
Yeah, I know the graph.
We need to scan the graph because they do treatment based off the graph in real time.
Like go back a couple of screens.
Sure.
I've been trying to take a couple pictures. I have a friend that's not able to be here today. This one. Nope, not that one. More. It's the one that had the different platelet or anti-platelet meds.
oh,
Right, this one.
right here.
Not that I'm trying to copy your stuff.
No, that's okay.
We just went to a trauma conference in Dayton, and we were like, we want this here in Lima right now, and so now she's missing it.
Oh, bless her heart. Well, Thank you.
Hi, Steve.
Hi, Elsa.
PFA, we have a PFA,
Mhm.
and we've had that for
100,
years,
yep,
yeah.
yep.
Do places, I mean,
Yeah, they
how do
replace it.
They just don't use it, right?
They replace it. Yeah, because PFA has its limitations, right?
Yeah.
And platelet mapping doesn't have those limitations, right? So you can, whether your hemocratis, H&H is low or, yeah, so, yeah,
They sort of gone by the wayside.
yeah, it goes by the wayside, yeah.
Okay.
But, sometimes, again, it takes time because people have to get comfortable with it. It's